I am going to quickly go through some slides because of the time. And I'm going to, Dr. Carr covered the IOM report. The update is very much the same with the percent of Americans having chronic pain. I did want to pause on this slide because of the 2001 survey that has not been redone, but 27% of the physicians reported prescribing compound analgesic creams. The only way we know that the use is on the rise is because of the claims data. And even though we don't have an accurate view of this because not everybody submits for reimbursement, we do know that those claims are up, especially with TRICARE and also Medicare, although most of the time Medicare will not pay for compounded creams. Medicaid will occasionally pay, in our experience, about 20% of private insurers. So we've talked a lot about the evidence. On the left, of course, is the Cochrane review that we all know about. The compounded creams have much less evidence, and we've also talked about that as well. Now, the effect sizes are highly variable, and the number to treat is large. We've talked about all of the different agents that are in the compound, so I won't review that. This study, though, I did want to pause on. I just pulled a few assorted studies, and that really depicts how variable that the regimens are. And I think the concern is that you can't use the cookie cutter approach, and that was true with the Brutcher study, where they did try 3 different combination creams with placebo and found no significant differences at all. But then there are studies that do show some significant differences that you will see on the screen. I think it really points to the fact that it's truly an art and a science and that there's no one approach. So what are the challenges in the literature? Really the mixed results that we see, the lack of long-term follow-up, the compounding variability. For example, the different concentrations of each agent in each cream, and also which one is working and which one is not working. I think we've all talked about that today. Adherence is not well monitored, and then the amounts and doses of the application are variable. And I'm going to talk a little bit about the metered doses in a minute because even though we have metered doses, patients don't always use those correctly. I do want to mention cannabinoids. Of course, we know there's evidence for that helping with both neuropathic and nociceptive cream. We have about 75% of the patients in our palliative care clinic that I would say ask about cannabis. And so many of them visit the dispensary. The creams average between like $20 and $40. They say that they're less expensive than the compounded creams. And so many patients do seek assistance here. They usually apply them twice daily. We tell them a little goes a long ways. And here's some of the products that are available. They even have some sprays. They've got pure CBD. The THC has to be prepared within the state, but others can be shipped. And again, patients are buying these products on the internet. I think the challenge here is how are we going to study this? We have some studies that are out there, of course, with it being a Schedule I drug. It's very hard to control and it's very difficult to conduct trials with. As far as the risk-benefit ratio, and that was one of the questions, for the minimal systemic absorption, as clinicians who prescribe some of these creams, we really rely on that and the evidence that has been in the literature. For example, with ketamine, there's a former report of 29,000 patients, and in addition to finding blood levels, we look at urine metabolites. 98% of the patients who had a ketamine cream actually did not have any metabolites in their urine, which makes us really think that there's very little systemic absorption. That's also true with diclofenac, but I think that the data are not readily available. They're out there, and we look for those, but they're hard to find as well. Also, when patients come to this point of needing an analgesic, a cream, it's primarily when they're refractory to other modalities. And so there is a placebo benefit for some, but it's the alternative option to other systemic opioids as well. We've seen the risks and challenges, costs we've talked about, adherence, and I'll talk just a little bit about access at the end. As far as safe dosing and application, so we can have the meters which dose, but I can tell you that patients find a way around everything. Because the dosing is so tailored and individualized, if they don't have enough money to pay, they'll use a half a squirt. Or they'll forget a dose, then they'll use more drugs. So even though the metered dosing is a good idea, trying to standardize it, we still find a lot of degree of variability depending on the patient, the age of the patient, the type of pain that they have. Adherence is also an issue. Many times when these patients are refractory to everything, even getting them to try something can be a challenge, and yet some patients are very desperate and will try absolutely everything. We see a lot of different social determinants of health that will depend on how well they do with these. If they have depression, they don't have a caregiver, they don't have the money to pay for the medication, of course, they're definitely going to have more challenges. Also being forgetful, the odors from the medications, difficulty applying in public. These are some of the things that they talk about. I think patient engagement is very important. So many times, speaking from a rural area, we have 1 million people in our state. We also border Wyoming. We have 3 compound pharmacies in Billings. There are 0 in Wyoming. We have 2 small towns with compounding pharmacies, which means most rural patients do not have access to these compounds. They rely on the pain clinicians in the larger cities. It's primarily the palliative care teams, the pain physicians. Primary care physicians don't even have enough knowledge to think about prescribing some of these compounded creams, so they come from specialists, which means the only way that they get these is to come to one of our teams. When they do, of course, in rural areas, pharmacies really help guide the clinicians. So at times, we'll look at the patient, the type of pain, is it mixed, neuropathic, nociceptive, try to formulate, again, it's that whole art and science, something that will try to help the patient. And even though the data is mixed, there's that occasional case that allows us to keep trying it in those patients who are refractory. We do have callbacks. Our nurse navigators call back 24 to 48 hours later, and then do follow-up visits as well. We reinforce, we try to give caregiver support. Part of my research activities in patient-reported outcomes and also in technology. So getting, apps to remind patients, because adherence to these products is not good. People put them on when they think about it, which might not be consistent. So there, I'll pause and have my colleague go next.